and great work on the radiation. I think it's honestly one of the biggest unmet needs in interventional cardiology. So looking forward to having you at OPCI and pushing everybody in this field. But I'm here to talk about intravascular imaging and SpectraWave, which is a new imaging device that is really designed to overcome some of the limitations of previous OCT catheters, but also really push the field forward in terms of resolution. So intravascular imaging improves outcomes. I think you've recently seen the plethora of meta-analyses, include the one by Greg and I in The Lancet, but also multiple randomized controlled trials. The Ultimate Study, IVUS XPL, Renovate Complex PCI, all showing us better outcomes. And I think this trend is clearly catching on. But there's also a new trend, and that is there is some interest in the potential vulnerability or high-risk plaques being identifying upfront high-risk patients that may be able to benefit from potentially prophylactic procedures, but certainly more attention paid to patients who are actually undergoing a PCI and are found to have another lesion with high-risk features. But here's the problem. The problem is we don't really have a device that's utilitarian to be able to answer all of these questions. Every intravascular imaging catheter has an inherent limitation as well as potential benefits. IVUS has excellent depth of penetration, but doesn't really have the image resolution to be able to see fine details. High definition IVUS overcomes some of that, but loses depth penetration. And OCT, while it has superior resolution, is fraught with this catheters issues as well as the flush problem, which actually makes OCT only applicable in 8 out of every 10 cases. So along comes the HyperView imaging system, which is a deep OCT and NIRS system. So it's combining two technology. One is OCT. It's got excellent resolution, but also near-infrared spectroscopy. What that allows you to do is perform PCI, but also identify high-risk features in a very easy way. Very different to what was recently done in the PREVENT study, where you had to be measuring plaque burden, measuring the minimal lumen area, identifying a thin cap fibroatheroma, and you'll notice that very few patients in that study actually use NIRS. So the HyperView imaging system, which is commercially available, FDA-approved device, is in our cath lab, allows you to evaluate morphology and composition, determine your stent size, and assess post-PCI. And when this device was developed, the first thing we said is that it must be a utilitarian intravascular imaging device. Don't make it a research tool, because if you do, it'll get buried. So right now it's a standalone cart. What's different about the HyperView system? First of all, the imaging resolution, which I'm going to show you shortly, is absolutely exquisite and unparalleled. The second thing, all of the things that we've been asking for in intravascular imaging devices are already built in. Artificial intelligence is included. The ability to detect calcium is included. The ability to detect lipid is included. The ability to determine the external elastic lamina is included. And the pullback is very fast, which means you can flush with saline. So you don't necessarily have to use contrast, which is another great feature. This is really what you want to see. You can see exquisite imaging resolution of inside the vessel at almost histology resolution. You can see the external elastic lamina very clearly. Intimal hyperplasia can be identified very clearly. But what about more complex plaque? Now, one of the nice things here is I probably looked at about 20,000 OCTs, and the first time when we did these studies in Colombia and the first in human, I saw things inside of the calcium that I've never seen before. And I said, what is that? And there may be the potential here to be able to identify the stage of calcification, whether you're at eggshell calcification, hard-boiled egg, or completely collagenized, very hard rock-like calcium. You'll also notice that the lipid is identified even sometimes when it's not so clear whether this attenuation is catheter-related, light-related, or actually attenuation because of lipid, as you can see in the NIRS spectrum, which is shown in the cross-section. Now, one of the things that's very interesting is that you may be able to co-localize calcium and lipid in the same place. What does that mean to you from an interventional point of view? It means you can break it easily because it's an eggshell, right? The inside of this is lipid, the outside is calcium. That means you might be able to break it instead of using shockwave lithotripsy, you can break it with a non-compliant balloon very easily. Again, when you're able to localize calcium and lipid but don't see any clear identification of lipid, it's directly intervenable. You can, of course, identify other features which are consistent with high-risk plaque, including thick cap fibroatheroma, but also, very importantly, thin cap fibroatheroma. And you can see the exquisite detail with the co-localization of the macrophages at exactly the site of the thin cap fibroatheroma. Really an astounding picture here. Plaque rupture, very easy to identify, and probably my favorite image of all the ones that we collected out of these 25 cases in the first in human in Colombia was this one, which is an eruptive calcified nodule. Look at this broken piece of glass, which is poking the intima, has penetrated it, and on top of it you have thrombus. I mean, that is histology level resolution. It's unbelievable. Okay, what else can you see? You can see intimal tears. You're able to very easily see vasa vasorum. Again, with the intimal tear, look what happens in plaque biology. You get an intimal tear, you have disruption of the endothelium, and you have thrombus on top of the vessel. Very, very easy to see. You can, of course, perform all of the other things that are relevant to PCI, which include understanding the stented vessel. Things like stent expansion and minimal stent area are all automatic, very easy, and really taken for granted. But the level of resolution allows you to see malapposition also very, very clearly. But I know what you're thinking. What's the big deal? What's already out there? And how much better is it? Well, this is the data, and this is the proof. Okay, on the left, you're going to see the Abbott Optis and the SpectraWave. So what is deep OCT? Deep OCT is the ability to see the layers of the vessel wall that would otherwise be obscured. And here you can see not only confirmation that the area at 9 o'clock is indeed lipid and not calcium, but also you can see the external elastic lamina all the way around the vessel, and the resolution in the adventitia is really unparalleled. Again, a head-to-head comparison of the Abbott OCT and SpectraWave in a stented vessel, and another one which again shows you the depth that you're able to see on the SpectraWave compared to the Abbott Optis system. And here's just a pullback side by side showing you the difference in resolution. So how does this help you practically? It helps you practically as we implement an algorithmized approach or a step-by-step approach. Morphology, what are we looking for? Calcification in lipid, it is automatic. On the cross-section, you see the following. You see the calcium identified on the cross-section. On the angiogram, co-registration is standard as part of this device, as well as on the automated lumen profile on the bottom. We spent a lot of time building calcium scoring systems for you. For example, the rule of fives for OCT. The rule of fives is automatically set at the bottom. It's telling you that the thickness of the calcium anywhere that's highlighted blue is more than 0.5 millimeter thick, more than 50% of the vessel arc, and more than 5 millimeters in length. Hence, it needs advanced lesion preparation. You can do the same thing in the post-PCI assessment. Malapposition is detected automatically. The edges of the stent are detected automatically, which allows it very easily to identify edge dissections, and expansion and minimal stent area are displayed for you automatically. What about the difference between IVUS? Right, so one of the selling points here is the depth. Well, here's head-to-head comparison between Boston Scientific OptiCross. You can see that you can probably see the depth even better on the SpectraWave compared to the IVUS. Another example of 40 megahertz IVUS. One of the problems with IVUS, of course, is the inability to penetrate calcium. Here you can see very clearly fully collagenized calcium. This is rock. Okay, there's no question. You're not going to be able to break this with a non-compliant balloon. You're going to have to do something more advanced to be able to break this. No lipid signal inside it at all. So what you can see here over and over again is not only a superior imaging resolution, but new utility, because these images are all taken with saline. This is not a contrast flush. The pullback is so fast, you can actually clear the blood very effectively, and the pullback happens in 1 second, so you can do really heartbeat OCT. So what are the things that we can assess from a vulnerable plaque point of view? I showed you cap thickness, I showed you plaque burden, I showed you lipid core. All of the things that we're using to prevent tile are all automatic. And to be honest, you can just select them on the menu. So if you want the minimal lumen area set to be a certain threshold, if you want an LCBI of 315 or 400 or whatever your choice is, it'll just pick it up for you automatically. So in conclusion, the HyperView imaging system is the next generation deep OCT in NIRS that's got co-registration, a very low profile, the shortest rapid exchange. I didn't mention that. The catheter actually gets way out into the branch vessels because the rapid exchange is the shortest of all commercially available devices. The workflow is really set up to make it easy. You don't have to set up anything except plug it in. There's no flushing. You just go ahead and pull back. And finally, you've also got the NIRS with co-registration on top of this, which really, I think, is leading the way for the next generation of imaging. Thanks very much.
Ziad, can I ask you a couple questions?
Yeah,
one is, do you think AI is going to improve the use of invasive imaging across, everywhere in the U.S., et cetera?
So, people don't use things when they don't understand it, and when you can make it easier for them to understand by getting a computer to do it, that does two things. One, it improves and increases adoption, and then the second thing, which I think is actually more important, it creates more standardization.
And then my second question is, you're going into this histology. I mean, basically it's histology, right? So where are we going? Where do you see this going in terms of PCI? Are we going to do preventive stenting? What's your vision?
So, having looked at PREVENT in great detail, this is my take-home message from PREVENT. If you're going to put a stent in the LAD and you have a high-risk plaque in the circumflex, you've already paid for the imaging catheter, and the risk of performing that PCI is so low, then I don't have a problem with performing PCI on that vessel in that. I don't think we're exactly there yet to go and just see a 50% lesion image it and then start putting stents in, but I do think that we're opening the door to treatment of vulnerable plaques. And all of the studies that we've done on vulnerable plaques all show the same thing. You got to wait between 2 to 3 years to start having events.
Okay, great.
Can I ask a quick question? That amazing presentation, amazing technology. One of the criticisms of surveillance IVUS in heart transplant rejection in cardiac allograft vasculopathy is that it becomes a little bit subjective, and it varies from year to year in terms of how it's imaged, the segment that's imaged, and so forth. Do you see an application there?
Sure. I think we used to do a lot of this at Columbia as well. I think the real value of this is the resolution, which allows you to see it very clearly in the automatic measurements. So if you're doing serial imaging, to be honest, with a lot of those people having CKD with saline, you can very easily set your metrics to say, is the minimal thickness more than 0.5 millimeters, identify patients at high risk who need, changing their medical therapy, and make it very actionable.
Let me follow up with a question on research in these areas. You cited IVUS XPL, Ultimate, Renovate Complex PCI. We've got good data, and of course, Illumian 4, probably important to mention that to you. We've got good data that intravascular imaging improves outcomes. Right? At what point do we say, look, the images are so much better with this new device, we don't need a large randomized control trial to say this improves outcomes? Do we need a large randomized control trial with each and every iteration of these devices to show that these should supplant their predecessors?
No, I don't think so. I mean, we didn't do a trial for every company's FFR, right? Just because we called it the same thing, right? But now if you call one IFR and one DFR, you have to do a separate study. It doesn't make any sense, right? Look, the European Heart Journal document and consensus was pretty clear. All intravascular imaging modalities do about the same thing. They make you cover the plaque, they elongate your stent, and they make sure that you don't leave crap behind. That's the benefit. And on a population level, that provides a benefit if you enroll enough patients. Now, I think with the network meta-analyses as well as total volume of data, I mean, you reduce death. Even DS don't reduce death. So, I mean, we're past the point of just a signal now. And I think, further randomized trials. Now, on top of that, we have IVUS ACS. I mean, how much evidence do you need?
Agreed. All right. Well, thank you very much. That was great. All right. Last but not least.